Dr. Gary Fettke here from Tasmania, long way away from a lot of you, and it's good to catch up with you, albeit in this format. Obviously, I've had a fascination for the topic of sugar and carbohydrate for a long time now, and it's great to see that there is a growing awareness of the damage done by excessive carbohydrate intake. But one of the things which has interested me is how much is too much and what alternatives do we have. So it may surprise you to see that anything more than 1 teaspoon is treated by the body as being toxic. It all comes down to biochemistry. So we managed to evolve over 2.5 million years and get to the top of the food chain as hunter-gatherers. And we were eating obviously fresh, local, seasonal food, which by definition was low in carbohydrates and higher in healthy fats and protein. Our carbohydrate intake was primarily seasonal from fruit and certainly not all year round in the amounts that we see today. Carbohydrate availability was uncommon in nature when we were hunter-gatherers. Around 10,000 years ago, we had the onset of the agricultural revolution, the development of cropping and farming practices. And since then, our general health has deteriorated. The last century has seen an abundance of refined carbohydrate and processed food, and with that, our health has exponentially declined. So I have no commercial conflicts of interest to declare, but I do want you off sugar, and I am a long-term advocate for a low-carb, healthy fat lifestyle. We should define carbohydrate. Carbohydrate is either glucose or fructose, or found in combinations. Both are different organisations of the same molecular structure, combinations of carbon, hydrogen and oxygen. Complex carbohydrates are just longer chains of glucose and fructose combined together and then broken down to the simple structures in the digestive process. Carbohydrates are unique in that we have biochemical pathways for them even though we have no requirement to actually eat them in the first place. When carbohydrate is not available in the diet, the body will produce just enough for its requirements. When it has an excessive amount, the human body goes to great lengths to remove it from the bloodstream. I repeat, the human body goes to great lengths to remove it. We do not have a safe transport mechanism for carbohydrate in the blood, and its presence has toxicity, particularly in the amounts commonly eaten today. The interesting issue is how rapidly the body removes these molecules from the bloodstream. Glucose and fructose are not transported well in the blood, and they are generally dissolved in it. Both are rapidly absorbed from the gut, and the body's metabolism does everything in its capacity to remove them from the bloodstream as quickly as possible. Our metabolic pathways go to great lengths to stop an elevation in the blood glucose and via separate pathways in the liver to metabolize and remove fructose from the bloodstream. The human body does not like leaving glucose nor fructose in the blood. So why are they removed so actively? Just maybe glucose and fructose in excess are toxic. By contrast, the body maintains a safe and efficient mechanism of transporting protein and fat in the bloodstream in the form of lipoproteins. Those lipoproteins vary in size, density and proportion of protein to fat and are known by their particle names. Lipoproteins safely move fat and protein around the body. We don't have a safe and efficient method of transporting excess glucose apart from it being dissolved in the blood. Therefore, I'll argue that anything beyond a normal blood glucose becomes the problem. So clearly, too much carbohydrate is harmful. But could that dosage be as small as 1 teaspoon? The bloodstream can only manage 1 teaspoon of around 4 grams of glucose at a time, and excess provokes a physiological response which is harmful to the body. And then we have fructose with its own unique metabolic properties which can be harmful. So let's define toxicity. Toxicity of most substances is dose-related. With carbohydrate, it is the excess beyond requirements. And when that excess has a negative effect on the system. So we're going to cover a few topics. How does the body handle carbohydrate normally? What are the differences between glucose and fructose metabolism and their harmful effects? The circulating level of glucose in the bloodstream is about 5 millimoles per litre or 9 milligrams per decilitre. That is around 4 grams, which is approximately 1 teaspoon. Anything in excess of 4 grams of glucose needs to be removed from the circulation, and does that have potential harmful effects? And so then what happens within the tissues when that glucose level becomes elevated? And I'm going to cover the mechanism of action of that damage and describe both direct and indirect mechanisms. And then we're going to look briefly at other damage that is documented with carbohydrate excess. And if I'm going to demonise carbohydrate, then we need to carefully consider alternative fuel sources such as ketones and see if they're actually safe. And then I'm specifically going to present the case of that safety in relationship to pregnancy and infant growth, the most important times when nutrition is critical for outcome. So back to our understanding of carbohydrate. There are only effectively two molecules in carbohydrate. Complex carbohydrates are those repeating chains, and despite having very similar structures, glucose and fructose have quite different metabolic pathways. And the definitive description of fructose metabolism was only as recently as 2010. So carbohydrate comes in a variety of sources and a variety of names. But in the pre-agricultural revolution, the natural sources were seasonal fresh fruit and honey, a small amount of glycation in meat, and breast milk. So from an evolutionary aspect, these would have been our only effective sources of carbohydrate intake. Now, some of you heard me speak to this before, but carbohydrate, amino acids from protein and fatty acids from fat are the fuels we can utilise in our cells. The mitochondria convert those fuels into adenosine triphosphate, ATP, and then that ATP is then utilised as an energy source throughout the body. Basic physiology describes how the Krebs cycle converts acetyl-CoA into ATP. The acetyl-CoA can be effectively sourced from either glucose, fatty acids, or amino acids from proteins. There are essential fats and essential proteins that are required in the diet, but there are no essential carbohydrates that are required for mitochondrial function. Mother Nature has not made us dependent on one seasonally available carbohydrate. Well, that's science. Inside the mitochondria, it's about science, and outside of the cell, food has become about politics, money, and emotion. That's non-science, and that non-science has been extensively covered in some of my previous talks and Belinda Fettke's presentations. So there's a lot of misinformation on what is our actual glucose requirement. There are very few cells that only require glucose as their energy source. Those cells do not have mitochondria. Red blood cells and some cells in the lens of the eye and the thin cells in the loop of Henle in the kidney require glucose as their energy substrate. The small amount of glucose does not need to be eaten. So despite misconceptions, the brain is not dependent on glucose as its only fuel source. The brain has mitochondria and will manage very well on a combination of lactate, ketones and glucose sourced from gluconeogenesis. Gluconeogenesis gives us enough glucose for that cell activity and does not give us hyperglycemia. The body does not chronically overproduce glucose. So glucose can either be eaten or created from the breakdown of stored glycogen, glycerol and triglycerides, or via protein conversion and gluconeogenesis. That created glucose is for metabolic need and is not produced for excess. That is left to our ingested consumption. So when we eat it, glucose is absorbed from the gut and then distributed around the body under the direct effect of insulin. The excess glucose requires immediate removal from the circulation. When those processes fail, we have diabetes. Insulin is the major hormone moving glucose out of the bloodstream and into the tissues. A chronic excess glucose load results in hyperinsulinaemia, and there are detrimental effects of a chronically elevated insulin secretion. So how much glucose do we need to ingest before we trigger an elevation in the blood glucose and therefore trigger that insulin response? Well, that amount is around 4 grams, or that 1 teaspoon. To put that in perspective, one slice of bread contains around 5 teaspoons of glucose. The immediate metabolic requirement is for around 1 of those. The other 4 teaspoons need to be taken out of the bloodstream under the direct influence of insulin. Otherwise, the blood glucose level goes up, particularly in those with diabetes. When blood glucose rises, there follows an elevation of glucose in the interstitial fluid as well as all tissues. There are mechanistic issues in causing damage, which can either be direct or indirect. So let's look at hyperglycemia. It is the clinical issue of too high a blood glucose. The complications of that elevated glucose can be acute or chronic. A prolonged elevation of blood glucose manifests as diabetes. Acute complications include agitation, fatigue, thirst, and increased urine output. And I recognise that this is not going to occur with one slice of bread, but it is indicative of the issues related to an elevated blood glucose. And in extreme situations, hyperosmolar syndrome for type 2s and ketoacidosis for type 1s. These people are generally ill from other problems, and neither of these states are nutritional ketosis. Nutritional ketosis is a perfectly normal metabolic state that we can drift in and out of when you skip meals or fast. So what are the chronic complications of your blood glucose being too high? Organ damage is significantly caused by advanced glycation end products known as AHPRA. The damage over time is directly related to chronic disease, organ failure, and ultimately death. So, how do advanced glycation end products cause damage? We've all seen the browning of toast, cakes, and biscuits. That's called the Maillard reaction. Glucose binds to protein, and under the effect of heat, the slice of bread goes brown. The same thing happens in your tissue. High glucose levels combined with the protein, and under body heat, the Maillard reaction takes place. That reaction makes tissue stiffer and inflamed. So every time your blood glucose spikes up, you are effectively toasting your brain, your eyes, your kidneys, your vessels. This toasting is occurring in every organ of your body every day with an elevated blood glucose. Welcome to the complications of poorly controlled elevated blood glucose. Oxidation affects not just proteins, but also glucose and lipids. And once oxidized, these molecules become part of the overall inflammatory process. There's also the polyol pathway conversion of glucose to fructose, releasing inflammatory oxygen-free radicals along the way, and they have the same effect as advanced glycation end products. We can measure the effect of AHPRA in the blood, and the common test for diabetes control is the HbA1c. It is a measure of the damage done by those AHPRA on erythrocytes and measures that effect over approximately the previous 3 months. The higher the percentage, the greater the damage. So what do those advanced glycation end products do? Well, they account for organ damage at a tissue level, at every tissue level. They can affect the brain, causing issues from dementia, now being considered as type 3 diabetes, through to mental health and strokes. It is a mechanism causing diabetic retinopathy and macular degeneration in the eyes, peripheral vascular disease, heart attacks, kidney failure, peripheral neuropathy, foot ulceration and amputation, wound healing and the infection in all of its forms, and cancer. End organ damage is what kills you. Slowly we die from the excess glucose in our blood and tissue. An elevated glucose level creates damage in all tissues by a combination of AHPRA as well as glycation of tissue proteins and fat. The protein damage is not just to structural proteins, but also to messenger protein, the very backbone of our DNA. However, what happens to the largest organ of the body? Many of you may be surprised to realize that it is not the skin, and it is in fact our Glycocalyx. The Glycocalyx lines all blood vessels and has a surface area of 4,000 to 7,000 square metres and a volume of approximately 1,700 mils. It is metabolically active and produces nitric oxide. Nitric oxide is a potent vasodilator that is critical to control blood pressure as well as microcirculation at the capillary level. The Glycocalyx is the gateway layer in transportation of nutrients and chemicals across blood vessel walls. It is a complex lining of every blood vessel made up of a combination of carbohydrate and protein in the form of glycoproteins, polysaccharides, proteoglycans, and glycosaminoglycans, thereby rendering the entire layer susceptible to changes in blood glucose. The Glycocalyx is probably one of the least understood areas of the body, yet critical to our homeostasis. Pellinger and Camp's 2017 review of the endothelial Glycocalyx gives an excellent overview, including the damaging effect of diabetes. The Glycocalyx is fragile, and most modern lifestyle and environmental factors are likely to damage it. in particular carbohydrates and their metabolites. Some of these factors overlap but have all been documented in the literature. The damaged Glycocalyx results in an increase in vessel permeability of all substances. When the Glycocalyx is damaged, it not only loses its ability to produce nitric oxide, but the damaged layer creates an increased permeability of blood vessel walls. This is a similar concept to what we understand as leaky gut in the intestine. The breakdown of tight junctions increases susceptibility to toxic material crossing from the gut into the bloodstream. The loss of Glycocalyx layer allows material to move out of the blood into the tissues in an uncontrolled fashion, thereby rendering every corner of the body susceptible. Glycocalyx recovery from an acute glucose load can take hours to recover. Some studies claim that the recovery time frame may be 5 to 7 days. Diabetics with chronic hyperglycemia have an average 50% reduction in Glycocalyx thickness and resulting increased permeability and thrombosis potential. The Glycocalyx damage is greater with poorer control of blood glucose, as evident in the type 1 diabetes population. The poorer circulatory flow and increased permeability place those with diabetes at much higher risk of cardiovascular compromise and organ failure. So, after considering the direct effects of an elevated blood glucose, there is the added indirect effect on the whole body as a result of elevated insulin secretion. Now, we know insulin has multiple benefits to us from an evolutionary standpoint, and particularly in its use as a fat storage hormone. But modern society now has such a plentiful supply of food, and the evolutionary benefit of insulin is no longer required. That chronic elevated secretion of insulin comes with an entire set of problems. Insulin is secreted when we have an excessive carbohydrate intake, and as said earlier, primarily stores that excess as fat. But insulin is also a tumour growth hormone, and probably the most influential one. The hyperinsulinaemia state is associated with higher rates of cancer and poorer outcome. A lesser known effect of insulin is that it is an inflammatory hormone as well. Recent 2020 literature has shown insulin to have a dose-related effect on synoviocytes in the knee. These are the cells lining the knee joint and primary cells responsible for inflammation. Reducing insulin load to these knee cells reduced inflammation. Increased insulin increased inflammation. Now, I know that paper wasn't written by a low-carber, as they concluded that insulin should be targeted with intervention, completely missing the point that the lowest levels of insulin secretion are related to low-carb dietary intake. The insulin effect gives a background mechanism to those patients with osteoarthritis having a symptom reduction when adopting a lower carbohydrate intake well before they lose significant weight. I see that benefit every week in my patients. Insulin also depletes magnesium, which is required in multiple biochemical pathways, and higher levels of insulin reduce vitamin D activity. And that overall increases the prothrombotic state with a higher risk of deep vein thrombosis and pulmonary embolism. Glucose has direct and indirect effects on the tissues. Fructose has its own. Once again, it has both direct and indirect effects, particularly in the non-physiological state, as we are no longer hunter-gatherers. The following is a brief overview of fructose metabolism and its effects. Further information on my talks on inflammation cover this in more detail. So fructose is similar to glucose but metabolized quite differently. It is mostly metabolized in the liver on a first-pass basis. A small amount is metabolized in the gut and the mesentery. The absorption and metabolism can be upregulated depending on intake, and this suited us as hunter-gatherers when increasing our fruit intake when it was seasonally available. From an evolutionary aspect, fruit is generally in excess at times of plenty to be stored away as fat for winter hibernation. The major issue now is the oversupply and daily availability of fructose. So fructose, a small amount is metabolized to glycogen storage. A significant amount travels via the aldehyde pathway, which is effectively turning the fructose into alcohol, and that has damaging local effects within the liver. One of the byproducts of fructose metabolism is uric acid, and when fructose is consumed in excess, then we have an increased production of uric acid, which manifests itself as gout. This is obvious when it precipitates into the foot, but low levels of elevated uric acid are likely to be playing a role in a range of inflammatory tissue conditions. The other major effect of uric acid is on nitric oxide production. This is separate from the direct damaging glucose effect on the Glycocalyx in the blood vessel walls that was referred to earlier. There are 3 forms of nitric oxide, and they are all affected by uric acid. Uric acid inhibits nitric oxidase, resulting in a reduced availability of nitric oxide throughout the body. The 3 forms of nitric oxide are neuronal, which maintains the brain blood supply. There's the endothelial nitric oxide produced by the Glycocalyx, acting as a vasodilator and effectively controlling our blood pressure and microcirculation. The inducible form is integral to our immune function and effectively allows white cell mobility. Again, uric acid inhibits the production of all 3 forms. The increased production inhibits nitric oxide availability of the brain with a reduction in brain blood supplies. It has implications in dementia and mental health. When we lose the vasodilatory effect, hypertension follows, and we regularly see an improvement in blood pressure control with a reduction of sugar in the lifestyle, once again before an associated weight loss. Uric acid reduces white cell function and is associated with poorer immunity and higher infection rates. There is a central role of considering nitric oxide in cancer management. Fructose is involved in the development of insulin resistance in muscle and the liver, and this compounds the hyperinsulinemia seen with prolonged exposure to excess glucose consumption. Fructose is involved in the development of leptin resistance at the hypothalamus, affecting appetite. Again, this is beneficial from an evolutionary aspect for fat storage, but not in our current food availability state. Leptin is normally secreted from fat when there is plenty on board. It normally acts as an appetite suppressant, but when inhibited, contributes to the hunger and food addiction. Fructose also stimulates ghrelin secretion, which makes your tummy rumble, also contributing to the hunger sensation. All useful in evolution, but not in our current obesity issues. Fructose is ultimately metabolized and transported as a small, dense lipoprotein, which is prone to oxidation. These oxidized particles are implicated in cardiovascular disease and inflammation. An excess intake of fructose is associated with a significant increase in small, dense LDL production. The greater the intake, the higher the small, dense LDL production there is, and once oxidized becomes the cardiovascular catastrophe, which is being played out in society right now. Previously described in my inflammation talks, there is a polyol pathway that converts up to 30% of ingested carbohydrate into fructose. This only compounds the direct harm issues related to excess glucose as well as fructose consumption. There are other harmful issues associated with carbohydrate intake. As far back as 1973, it was documented that consumption of sugar and glucose was associated with a reduction of immune function. This reduction was measured as a phagocytic index. It was a measure of how effective white cell neutrophils consume bacteria. A reduction in immune function was observed for 5 hours after eating carbohydrates. This paper alone raised my concern about post-surgical food, and why do we give patients sandwiches, fruit juice and cookies immediately after surgery when this has a clear detrimental outcome on our immunity? An interesting side note to that study was that the phagocytic index continued to improve the longer the subjects fasted. The ketotic state that would have been achieved by 60 hours appears to have been beneficial on our immunity. Unfortunately, post-operative fasting for 2.5 days after surgery is unlikely to be enthusiastically embraced by my patients. So this detrimental effect of glucose on phagocytosis has been reproduced in other papers. It's almost as though this basic physiology of our immune function has been ignored for decades. Elevated blood glucose is well documented to create poorer function across most blood cells, which affect immunity and clotting states. Small glucose loads can increase erythrocyte aggregation within minutes, which is part of a prothrombotic state. Osteoarthritis is now seen to be an inflammatory condition rather than purely a wear scenario. Advanced glycation end products appear to be the damaging molecule of articular cartilage. That combination of ages and oxygen-free radical formation contribute to articular cartilage damage. This is exacerbated by the inflammatory effect of insulin, as discussed earlier. At the cartilage level, we see the byproducts of carbohydrate metabolism causing harm. We do not see the byproducts of protein and fat metabolism. I was discussing this with an orthopaedic colleague who has an interest in ancient skeletons. Pre-agricultural revolution skeletons do not have the osteoarthritis picture that we currently see, is that because of their reduced carbohydrate and inflammatory lifestyle. Likewise, those same byproducts of carbohydrate metabolism are present within degenerate tendons. What was once thought to be a wear and tear issue of tendons turns out to be an inflammatory problem secondary to the same ages and oxygen-free radical production that is occurring in joint cartilage. I looked through the literature to see if the same process was occurring in the discs of the spine, and that has not been documented. The harmful effects of carbohydrate appear to be localized to the cartilage and the tendons rather than the spine. Across all specialties, there are higher rates of postoperative infection associated with perioperative hyperglycemia. So to truly consider if carbohydrate in excess is toxic, one needs to look at the literature to see if the removal of the toxic substance results in improved outcome. And removal of glucose loads is documented to improve Glycocalyx thickness and function within hours to days. The removal of fructose in an isocaloric fashion results in improvement in non-alcoholic fatty liver disease within days. Lower carbohydrate lifestyle changes are documented in multiple randomly controlled trials to be the most effective method in improving weight loss and diabetes control. The significant reduction of glucose, certainly in excess, is a central factor in the majority of studies. Lowering carbohydrate intake improves cardiovascular risk profiles across multiple markers. So I've made the case of toxicity of carbohydrate and the lengths that the body will go to remove it from the circulation. We evolved over a couple of million years without substantial carbohydrate in our diet and therefore sourced our energy requirements from protein and fats. So after demonizing carbohydrates, then I need to prove that the other option of fueling the body in the form of ketones is actually safe. So what evidence do we have that a diet higher in fat intake resulting in nutritional ketosis is not only safe but likely beneficial? So to prove the safety of an intervention, ideally we should have human trials. There should be large numbers involved in those trials. There should be firm endpoints to study. And we should be able to control timeframes in those study populations. There should be good follow-up data. The results should be reproducible, and ideally multi-centre trials reaching the same conclusion. The results should be published in peer-reviewed literature and be applicable across international boundaries. We may already have all of that literature at hand. In the last few years, I've given that some thought, particularly in the view of becoming a grandparent once again. Our elder daughter struggled with morning sickness for several months and was in a state of continued ketosis, not just by choice, but by situation. It made me look at the literature relating to that state of constant ketosis and the results in pregnancy. The fetus, babies and young children grow in a state of ketosis. Our most important development period demands a state of ketosis. And I'll quote Angela Stanton, who's done some extraordinary work in this area, putting together some of the papers that I struggled to find, and it is worth looking at her work. So our most important development period is dependent on a state of ketosis. Newborns and infants spend significant amounts of time in ketosis and take very short periods of time to drift into that state. Ketosis is a normal state in fasting pregnancy for newborns, in infants and children through to 4 years of age. All stages utilize ketones as a fuel source, and it is clearly the safe mode for the human body, and we appear to thrive in that situation. Growth is in fact dependent upon it. So pregnancy is clearly a critical period for embryonic and neonatal development. Maternal nutrition is obviously central, and the literature abounds with pregnancy-related outcomes, which leads me to consider the case of morning sickness, otherwise known as nausea and vomiting in pregnancy. Severe morning sickness, generally occurring in the first trimester, is quite common. If the mother doesn't eat, then she clearly moves into a state of ketosis. The more severe the morning sickness, the greater the state of ketosis and the longer the periods of time within it. This makes for an interesting group of women to study the outcomes of the pregnancy. The opposite end of the spectrum is that of gestational diabetes, which is also common. It is a state of both maternal and placental elevated glucose. Multiple endpoints are well documented in the literature. for both severe nausea and vomiting of pregnancy, as well as gestational diabetes. So I've combined multiple studies in my literature study, and there were consistent findings. The literature strongly supports the following. Those women with significant morning sickness and likely state of ketosis bear children with a lower rate of birth defects. They have a lower miscarriage rate, and their pregnancies normally go through to full-term confinement. Their birth weights are generally maintained, and they have low complications of the overall pregnancy. Early childhood development in both cognition and health appears to be advanced. In contrast, those women with gestational diabetes have higher rates of children with birth defects, and those defects tend to be environmental rather than genetic. They are more likely to miscarriage and are less likely to get through to full-time confinement. They are more likely to have very high and very low birth weight babies, and are prone to significantly more complications through the pregnancy. And early childhood development, both from the cognition and health aspect, are poorer in comparison with those babies of women without gestational diabetes. There is a significant difference between the babies affected by ketosis in comparison with diabetes. Clearly, the state of ketosis is not harmful. So what can we conclude from this? The state of ketosis is required in critical development phases of life. If the state of ketosis is safe for the fetus and our babies, then it is clearly safe for children and adults. Is the benefit from a state of low glucose or one of low in insulin, or in fact both? Does the benefit come from a low glucose state or an increased ketone environment? My interpretation is that both are contributing. Again, my interpretation of literature is that a diet low in carbohydrates and higher in healthy fats is the optimal diet, not just for neonates and infants, but for all of life. Carbohydrates are common in our diets, but our body does not treat them kindly. Both glucose and fructose are moved out of the bloodstream as soon as practical because of their toxic effects. There is no single biochemical pathway that is dependent on ingested carbohydrate. The biochemistry is simple. More than 1 teaspoon is treated by the body as toxic. The fetus, babies and young children grow in a state of ketosis. Our most important development period requires a state of ketosis. The safe operating mode of our body is one of nutritional ketosis. The state of fasting and avoidance of carbohydrate in particular stimulates our immune system towards better health. So with the onset of the agricultural revolution around 10,000 years ago, we started to see the onset of modern disease. That is only compounded in the last 100 years with the increased intake of processed food and the significant carbohydrate component of that. Carbohydrate becomes toxic when it begins to have a negative influence on our body. It all comes down to biochemistry. And that dose appears to be just 1 teaspoon. So hopefully that has left you with some food for thought. Thank you all. Look forward to catching up with you all once again.
Yeah, excellent talk, Gary. I mean, it's interesting, isn't it? We hear a lot about glucose. We don't hear nearly as much about fructose. Are you a fructose fan?
Wow. It's, well, I have to say I used to be. And I say I used to be when I was addicted to the taste of sugar. Because as you know, fructose is more than 2.5 times as sweet as glucose. This is why, if you've ever wondered why, we have this high fructose corn syrup, why food manufacturers like it so much, is because that extra sweetness, it stimulates dopamine release into the mesolimbic pathway, and it makes it more. We know that if you can stimulate those sweet taste buds, it will increase the capacity for that food to, for want of a better term, to become addictive. And fructose is very good at that. But I guess also, as you know, so as Gary alluded to how, sugars can lead to small, dense LDL, that's because when the LDL particle becomes glycated, when it's been damaged by sugar, it actually fractionally shrinks. And that's what actually leads to small, dense LDL. And we know that the capacity that fructose has to cause glycation damage is somewhere between 7 to 10 times greater than what an equivalent amount of glucose can do. So, I mean, for all intents and purposes, fructose is really the elephant in the room. And unfortunately, at least in mainstream circles, it's really been let off. And the way it's been let off is through something called the glycemic index, which I'm sure you know all about. So the glycemic index.
Glycemic index is not something that you use in your practice?
Absolutely not. And I won't go into the exact nuances of all the limitations of it, but I'll tell you one of the major limitations is, so the glycemic index looks at the blood glucose response after a meal. And it basically says if you eat this, we'll just see exactly what your sugar response is, how much your blood glucose level will rise relative to a control item. Now, the trouble is, what happens if something doesn't have glucose in it, but rather it has fructose in it? So let's say table sugar is 50% glucose and 50% fructose. So that means table sugar will have a much lower glycemic index than an equivalent amount of pure glucose. Does that mean that because it's got a lower glycemic index, it's better for you? No, because it's really the fructose is Frankenstein in disguise. It's not showing up as blood glucose level. But yes, it is absolutely causing you problems. And this is part of the reason, I'm sure you recall when David Unwin came under his teaspoons of sugar infographic came under some criticism because it said, oh, well, when you eat a banana, it doesn't really increase your blood glucose levels by that much based on how many teaspoons of sugar he said it had in it. Well, technically that was true. But what it wasn't taking into account that it had fructose in it, which wasn't being measured in the blood glucose, but was worse, and it was actually causing more metabolic damage than the equivalent amount of glucose would have. So while his critics were technically correct, they were exactly opposite on the point they were trying to make. They were trying to make the point that these sugars in fruits were absolutely entirely safe and not as bad as Dr. Unwin suggested. In actual fact, his infographic, by considering all sugars as one for the sake of simplicity and communication, it actually downplays the deleterious effects of fructose-containing sugars.
Now, we're familiar, obviously, with table sugar, which, as you said, is 50% glucose and 50% fructose. But what about fruit? I mean, that's really the other big source of fructose. And we're all told, 5 a day, and fruit's good for us. But is it good for someone who's insulin resistant and type 2 diabetic?
I mean, isn't this just madness? It's only just recently that mainstream medicine has acknowledged that fruit juice is not beneficial. And somehow we like to tell people that the fruit in sugar is somehow magically better for you. So, and everybody says, oh, fruit's got fibre, that makes it magically better. So I was looking at a systematic review not so long ago on fibre, and, it was epidemiology, so we sort of take it with a grain of salt. But it made the very specific point that research demonstrates that fibre, when it is derived from fruit, may be associated with deleterious health effects. And in my mind, that's a non-brainer. It's like, it doesn't mean that the fibre from fruit is any different from the fibre you get from vegetables. But what it does mean is that when you're getting fibre from fruit, you're getting it with a truckload of sugar at the same time. I mean, if they're molecularly identical, I really don't see how they can have a physiologically different impact on the body.